Hey everyone, welcome to another edition of Healthcare Update for the week of April 11th. I'm Mike Howley, Director of Healthcare Management at the LeBeau College of Business. You know, one of my students was asking me this past week how I stay caught up on all of these healthcare things. And of course, I emphasize to my student, I have very broad breadth of knowledge. I specialize within a couple areas within that breadth, but I try to read widely. I have subscriptions to Health Affairs and the DIA Journal to cover the pharma area. I also have table of contents sent to me. As many of you know, you can go to these journals, whether it's JAMA and the New England Journal of Medicine, Kaiser Family Foundation, and they will push their news or their table of contents on you. I really like the Health Affairs blog with Timothy Jost. He has been doing a great job. He's an emeritus professor down at Washington and Lee. He's been doing a great job describing the details of many of these health proposals that are washing through Congress. I also look at the aggregators. Real Clear Health, Deloitte Healthcare Currents is a weekly newsletter, which is really good. I cruise the Fierce series, whether it's Fierce Pharma, Fierce CRO, Fierce Biotech, and I also subscribe to CenterWatch. So it's a lot of reading. I'm a fast reader, but that's how I do it. You might just pick one. Certainly, Real Clear Health is very kind of light, more news as opposed to health policy details. But then you can, and then on the next layer, get into Kaiser Family Foundation and the Health Affairs blogs, and then start checking out tables of contents. This Republican proposal for the American Health Care Act fell through recently, and most Americans say that that was a good thing. I was a little surprised by this. I didn't realize how much resistance they were facing in this. And of course, it breaks out by the respondents' politics, but across the U.S., 64% said it was a good thing, and 75% of Americans say that Congress should focus on trying to improve the Affordable Care Act rather than trying to completely reconstruct the healthcare system. News from the diagnostic and biotech industry. 23andMe received FDA approval for at-home diagnosis of gene variation, and they got approval for these 10 genes, these 10 diseases. A couple of things. Number one, very, very limited. So what are we, 15, 20 years into the genetics revolution? And this is what we can do, okay? Now, certainly if you have one of these diseases, it's really, really important. But when you get into gene testing, you tend to be talking about really small segments. And even biotech and pharma companies, very often now, they have treatments for genetic defects. Well, yeah, but you got to get the gene. You need to get the diagnostic test, so that really narrows the segment. These are not blockbuster drugs, so to speak. But on the other hand, so yeah, on one hand, this is something of a commentary on the failure of the genetics revolution. On the other hand, it is a trend towards patient-centered care. More and more, there are at-home diagnostic testing being done. Whether it's HIV or diabetes tests or whatever, more and more that's being done. A lot of this wearable technology has the potential to be diagnostic tests. I've heard of smartphone apps that are in the works for checking oxygen levels in the blood or even glucose levels. And this is all a push for patient empowerment. So I love that aspect of it. It's a commentary for physicians. When I was a PA in a family practice in the 1980s, the doctor stopped me one day, and we used to walk around with prescription pads in our back pocket in those days. And he pulls out his prescription pad and he says, "Remember, this is the only thing we can sell." And meaning that even back then in the 80s, before widespread internet access, consumers were gaining more and more knowledge about health and treating diseases. In the 20th century, in the 1950s, that was very exclusively the purview of physicians. It was secret knowledge, and that's why they wrote in Latin abbreviations their prescriptions, Grain 5, 1-POPRN. And that was a defensive measure to prevent other people from knowing what they were doing, okay? Well, even by the 1980s and certainly after the widespread use of the internet, medical information is a click away. So what do physicians have? Well, they have the prescription pad, right? Well, more and more drugs are going over the counter. Well, okay, so if they don't have prescription privileges, there's at least diagnostic testing. And so this is why I think the 23andMe genetic testing is interesting, because it's a breakdown of the last frontier, which is an ongoing trend. So if you're getting discouraged about patient centricity, patient empowerment, and there's certainly a lot of reasons to be a bit discouraged about that, this, in the long term, this is inevitable. Who knows? Someday we may even have, and a lot of people are working on this, patient-centered medical records, where the patient owns their medical records and it's maintained at one of the Apple, Microsoft, Google sites, and patients give permission for their providers to access their records. Finally, a comment. This was in this week's Deloitte Healthcare Currents. MACRA offers a bridge away from fee-for-service. And for those of you who are struggling with MACRA implementation, you probably want to scream. This is, and what this is within the health services sector, it's how the Center for Medicare and Medicaid Services wants to evaluate and even reimburse for health services. And the idea is, this is the first step in moving away for fee-for-service. Your SAR patient will pay you $50 or $60. Now they want to vary that patient based on the quality. And if you're going to do that, you have to document very carefully the quality of care. And so the MACRA legislation describes the quality payment program. And in the quality payment program, providers can choose from MIPS or advanced practice models. 80% of providers are going to end up in this merit-based incentive payment system, or MIPS. Now, one way to think about this MIPS system is that it combines things that many providers were previously working with. Meaningful use. Many of you are in the EMR industry or informatics. And so meaningful use has been rolled into MIPS. The value-based modifier payment, the PQRS, is now rolled into MIPS. And in the future, your payment will vary, and this will be phased in over the next 5 or 6 years. It will vary plus or minus like 9% at the maximum rollout. And your MIPS score will be based on the quality of care you provide, the resource use. They're going to start bringing in financial measures, the clinical practice improvement activities, as well as meaningful use, advancing care information. That's all going to be compiled. Now, who cares if you're in pharma or medical device? You have to understand, number one, if you're selling to providers or provider systems, they're really preoccupied with this right now. So you have got to show them with your pharmaceutical product, medical device, how they can get a better MIPS score using this. If you're in the informatics industry, the EMRs have got to automatically gather and calculate this, and the data entry has to be simplified. So I don't think that this is a great first step because of its incredible complexity. It's another huge, complex bill out of Congress, or this is regulations out of CMS, that is a shock to the system. So everybody has to be understanding what the health providers are focusing on now. So that's what I see, some of the things coming across my desk this week. I hope you have a great week. I'll see you next week.